Good morning, everybody, and welcome to day 2 of the 2023 Within Health Summit. My name is Jamie Singletary, and I am the Director of Clinical Brand Development for Within. And it is my honor to introduce my friend and colleague, Katie Peel, Clinical Lead at Within Health, who will be moderating this amazing conversation between Dr. Wendy Oliver-Pyatt and Chevese Turner. Take it over, Katie.
Hi, everyone. Welcome. We're so happy to have you here today at the Within Health Summit 2023. I just want to take a brief moment to introduce these two wonderful presenters today. First off, we have Chevese Turner. With over 20 years of experience, Chevese is an internationally recognized activist and advocate, speaker, policy influencer, and movement builder who dedicates her ability to make magnificent and significant social change on issues concerning eating disorders, weight stigma and discrimination, and intersectional social justice. She founded the Binge Eating Disorder Association in 2008 and successfully merged it with National Eating Disorder Association in 2018. And after 10 years that significantly changed the eating disorder community in both scope and focus, we have her here today. And next up, we have our fabulous co-founder of Within Health, Dr. Wendy Oliver-Pyatt, who is a world-leading expert on treating eating disorders. With more than 25 years of clinical experience, she has developed 5 distinctive treatment programs, all grounded on a strong biopsychosocial foundation and incorporating intensive psychotherapy with behavioral foundations and high medical standards. Wendy has developed a unique treatment approach that delves into the underlying issues that place a person at risk for mental health conditions and eating disorders that lead to healing, health, and inner peace. So we're so excited to be here today with you.
Can I just say one thing? That I think that magnificent, significant thing about Chevese, I just want to say that that's true. Magnificent and significant. I love that.
Right back at you. It's a love fest.
So the title of our session today is Championing Change, Weight Stigma Awareness Week. The co-creators speak. So we have our wonderful co-creators. Would you tell me a little bit about Weight Stigma Awareness Week and where it came from and where it is now?
Chevese, would you like to give that background?
Sure. Way back during the early years of BETA, we noticed that there was just so much weight stigma within the field of eating disorders. We suddenly had all of these people coming into the field who had a range of bodies, but more fat bodies than we were used to seeing in the field. And so Wendy wisely in 2011 mentioned at a board meeting, we should really do some sort of awareness day or week or month around weight stigma, because it's something that is just not being spoke about in the eating disorders community. And it affects the range of people. Everyone with an eating disorder benefits from learning about weight stigma and how it affects them. So we started Weight Stigma Awareness Week, which is always the last week of September. And outside of the few COVID years, we've been doing it every year since. And this year we had a lot of really great speakers, and those speakers, their talks will be available again. We recorded them all and we're working on getting them up on YouTube and on the website at weightstigmaawarenessweek.com. So you'll be able to watch those and share them with family and colleagues and friends and so forth.
Yeah. And what I would like to just maybe add to that is that, weight stigma, as like Chevese was mentioning, it affects all forms of eating disorders, and I know Chevese agrees, it affects our communities in incredibly profound ways. It really is in all walks of life. It's in government, it's in academia, it's in treatment centers, it's in schools, and it's for sure in healthcare. And actually doctors behind families are the number 2 perpetrator, if you will, of weight stigma. So in addition to just all forms of eating disorder being grounded in weight stigma in some way, shape, or size. It permeates through, our communities at large. And, there's really, people don't really have a language for it. I mean, aside from those in our field, like, the average person, layperson, has probably never even heard of the term, weight stigma. They probably never heard of other terms like, weight cycling. They think using the O word is perfectly fine and don't understand why anybody should have a problem with it. So it's a really far-reaching issue that really, like Chevese always talks about, so it is also about a social justice issue, and it's about the healthcare community abiding by that first do no harm principle, which, currently that is not what's happening, because it is a first do harm thing when it comes to weight stigma. And it is much more normalized and much more, what's to be expected. If you're living in a larger body and you proceed, if you seek healthcare, you're going to probably experience, weight stigma. I was just at a Florida Psychiatric Association meeting, and I was sitting there with a couple of doctors that don't really understand what it was. They could understand how shame would possibly cause some problems. So I was able to say, they were, oh well, yeah, shame probably. And I was like, how do you think shame feels interpersonally? Well, it creates a gap, an interpersonal, it causes a wall interpersonally. Shame is an emotion that buries people, right? It pulls people away. So I was able to sort of connect the dots. So if the doctor is doing and saying things that are shaming, what is actually, happening in the interpersonal bridge? They were able to say, they actually started off by saying that connection is the most important thing in the doctor-patient relationship. So it's like, okay, if that's true, then what the doctor is doing is causing shame. It was able to, like, do you see? So I was able to sort of break through that, and to get, but I really think that weight stigma awareness, like things like, racism, is something that is obviously still, prevalent in our society, but at least it's not theoretically socially sanctioned. It's like not allowed. And I think at some point in our society, I hope to God that at some point in time, it'll be something that's like more of a normative term. People know what it is, and they will know when they see it and smell it, and they will object to it. My goal is for people to object to weight stigma.
Can I add just one little thing? I want to mention that you mentioned racism, and what we know now is that weight stigma actually comes out of racism, that it was born in racism, because during the slave trade in early England, it was, white women did not want to have bodies that looked like Black women. And so that is when it really became a distinctive issue, and we just have rolled from there. The other thing I want to say is, sometimes people will say to me, well, I was made fun of because I was thin or underweight and that sort of thing. And we recognize that weight stigma does harm people across the spectrum of body size, especially when it's internalized and when you feel like your body isn't right because of, society and the way it talks about bodies. But the truth is that only fat bodies are actually oppressed. So when you live in a body that's the societal norm, that body is not oppressed. Right. You are not eliminated from the built environment that's out there. You fit into chairs. You are not discriminated against in the workplace or in housing, at your doctor's office and so forth. So when you have that sort of gut reaction of, oh yeah, I know this, you've internalized all of that, and you may be beating up on yourself on the inside, but it really is fat people who actually experience the oppression. So just keep that in mind as we're talking through this today.
Thank you for pointing that out. And I think that's something that Chevese and I talk about too, because the reality is that, like, this is an issue that I care a lot about personally. I care a lot about it, but I haven't experienced the actual trauma and oppression of weight stigma. I'm I'm welcomed, to order a dessert in a restaurant. Nobody's rolling their eyes at me. And that's a very different reality. So those of us who want to advocate and be supportive, which I very much want to do, I think that, and Chevese has helped me really keep that in the forefront of my mind. So thank you for bringing that up. And I actually was thinking about it. I'm so glad you brought it up. I think all of us who haven't actually experienced the oppression of it, I think it's important for us to verbalize that as we want to advocate, and we still have to verbalize and understand it's a different reality when you're experiencing, macro and microaggressions like all throughout the day, every day of your life.
So we've talked a little bit about sort of the ways that weight stigma can impact individuals. And we've touched a little bit on medical weight stigma, family weight stigma, the racist background of weight stigma. I'm wondering if we could touch a little more maybe on some more of the key challenges that individuals facing weight stigma encounter in their daily lives, and how Weight Stigma Awareness Week is addressing these challenges. And then if we can roll into that a little bit, in what ways do you think weight stigma intersects with other forms of discrimination? We've touched a little bit on race, but also gender, socioeconomic status, and a little bit how Weight Stigma Awareness Week is helping to increase thought, increase action towards, combating these awful things that people encounter in their day-to-day lives.
I feel like we need 3 hours.
I know, right? Market set go should be 17 minutes.
Yeah. So I think one of the good examples that I have, since we're all in the eating disorders field, or most of us, is that when I worked on binge eating disorder specifically, one of the things that I saw at the very beginning was, this group of people with binge eating disorder, it took much longer to have it be a understood disorder, and we're still not at a place where the full field really understands it. And that is because of weight stigma. Restriction is a huge part of binge eating disorder, and yet most clinicians don't know that. Researchers don't study it. People with binge eating disorder don't realize it because they think they're doing the right thing. They think that skipping meals is good because they've binged earlier and took in a lot of calories. That's restricting. Dieting is restricting. When I was in the throes of my binge eating disorder, I actually went back and forth between binge eating disorder and atypical anorexia. And the difference, I was restricting in both of them, but with atypical anorexia, I wasn't binging. I was just straight restriction. And so this is really grounded in weight stigma, because the people that did the studies on the disorder could not understand that if you live in a larger body, you could also be restricting.
Exactly.
So Wendy, pick up on that, because I know you have a lot of experience.
Oh my God, I get, you can tell I just start going, ah. Well, we were actually texting about this morning, and I think it's really, really fascinating and screwed up that Albert Stunkard really started talking about binge eating disorder in 1959. He identified night eating syndrome. He identified like a dissociative quality to it. There was 3 components of what he identified, but it was basically binge eating disorder, had different ideas for names for it. And it really was well studied and thought through pretty specifically. And there was a period of time when there was a discussion about getting into the DSM. I believe it was in the late 1990s. There was heavy discussion about BED getting into the DSM. And then it was basically a political thing that put that to an end. And then BED made it into the DSM-3 in 1987, which was like how many years later? Like 30 years later, but under the category of EDNOS. And being there, it was considered a wastebasket diagnosis. And therefore, it was very difficult. And it still remains very difficult for reasons we can talk further about, but that are tied to weight stigma. It still remains something that the insurance companies don't take as seriously. And there's a way in which weight stigma is tied in with that. For example, we have in our, and I think this is a social Western society, no pain, no gain kind of mindset, that for those folks whose restriction in the case of BED leads to periods of dysregulation, that is sort of seen as there's a moral judgment around the dysregulation component. There's like morality woven into that goes back to deeper, roots that have to do with how we place value on different behaviors that people engage in, and how we place judgment on different behaviors. Whereas the restricting person elicits, we all understand that restriction and weight loss elicits a caregiving response. And that is one of the foundations of why, and sometimes people with anorexia nervosa, restricting anorexia nervosa, are very hooked to, actually they're addicted to being able to receive that caregiving response and that attention. And it's not because they're attention seeking, they're connection seeking. So the restriction elicits the caregiving response, whereas the dysregulation is more met with like a sense of repulsion and morality, judgment there, But on top of that, which we have to always keep this in mind too, is the idea that, and you mentioned it too, Chevese, that, not everybody that's living in a larger body is binging. So there's natural diversity. So there's, again, this other layer of assumption and stigma that anybody who is living in a larger body, they just must be sitting around eating, Cheetos all day. And this is just not the case, because there's just natural diversity. Similarly, people with binge eating disorder can live in a quote normal size body. So there's not this, direct correlation between body size, and behavior. And then there's certainly the atypical anorexia nervosa patient that Chevese mentioned. But this delay in BED getting into the DSM is undoubtedly caused by weight stigma. And Chevese, if you could be so kind to share with everybody the journey of BED in 1987 being under ED, NOS, to 2013 or 2012, when BED finally landed in the DSM, and maybe some of your work around that. I think it'd be great for people to know about that.
Yeah, I think that, it took so long, and it took a long time because there was a feeling within the DSM committee and the APA that, if we approve this, then all these drug companies are just going to want to make money off it because they'll want to sell weight loss therapies. And that indeed is happening, even though weight loss is counterindicated for people with BED. But even the researchers, to this day, it's really hard to get them to understand that they're essentially prescribing the eating disorder for an eating disorder, when they're prescribing weight loss. So that's a whole other issue that we could talk about for days, but it is part of the journey. And so when we finally got to the point where DSM-5 was in play, and the DSM-5 subcommittee on eating disorders was working, just prior to that, I had actually finally been diagnosed with an eating disorder after really having one since, early childhood. But my therapist said, I think what we're talking about here is binge eating disorder, but it's still not an actual disorder in the DSM. And I just was like, well, who do I need to talk to make that? I have a policy background, so that's kind of where my head goes right away. But I did then begin Binge Eating Disorder Association and started rallying the troops in a grassroots way. And in conversations with the committee, really was about, or at least what they said it was about, was making sure there was clinical utility to this designation, meaning that this was something that could be addressed in the clinic and that the possibility of recovery was there. So that to me was a little scapegoaty, but it was, it's what they were saying. So they finally felt like they had the studies, but indeed there were psychiatrists after the designation was approved who came out in public and said, we're just glorifying obesity and we are pathologizing gluttony. And that just told me how much they, A, didn't know about the disorder, and B, had internalized all the weight stigma and anti-fat bias. So it was, and we still, those people that were on that subcommittee, they're still trying to figure out how do we make, people with binge eating disorder lose weight if they're in larger bodies. It seems to be their I feel like they still don't understand their own diagnosis because they've researched it, but they haven't asked the right questions. And so that's what we as a community of researchers and clinicians who actually know this designation inside and out, we have to make that happen because we know what the disorder is all about. And there's a lot of trauma there.
Yes.
BED has the highest rates of trauma of any of the eating disorders. And I would suggest that that is because of weight stigma.
Yes.
When you're living with weight stigma day in and day out, which is a trauma in of itself, you are being re-traumatized over and over again.
100%. And what I would just like to maybe add to that too, and it's tied in exactly, tied into what you're saying, is the amount of trauma that happens in treatment settings due to weight stigma and very misunderstood around that. And that trauma has showed up in many different ways that I've seen with my own eyes very directly. I've received patients at my treatment centers that are stepping down from higher levels of care, and they come into my treatment setting and they're on calorie deficient, meal plans, and they're hungry and they're still binging, and it's because they're hungry. It's not because they have, they would be able to not binge. The first thing that you can ask somebody with binge eating disorder, what I always tell people to ask is, what's the last, after you binge, what's the last thing you ate before you binge? And it's like a carrot, some celery. It's not like, apples and peanut butter and chocolate milk. It's some celery, because the person's like resisting that physiological need to eat because of weight stigma and being shamed around their body size and shape. They've internalized the shame around eating, so they are not eating. And then when they do start eating, there's a propensity towards dissociation because of the internal barrier to eating actually causes a internal riff, if you will. Your mind is at battle. Your need to eat is at battle with your resistance to eating. So that riff actually is the nidus for dissociation. So through acceptance of our body and acceptance of the need to eat and embracing the need to eat, the person has a pathway to mindfulness, which means I can attend to my needs in hopefully a gentle and meaningful way. But we've also seen, in addition to caloric restriction for those with binge eating disorder, we've seen actual treatment programs that were literally boot camps, fitness, quote unquote, fitness camps that put people into excessive exercise protocols. And some of the people who put those programs together are still considered leaders in our field, giving keynotes, et cetera, at eating disorder programs, people who literally put together weight loss treatment and exercise. And there's something called exercise trauma, where, and I'm just saying that's a word, but I'm just, okay, I'm gonna use that term, exercise trauma, where the person has been mandated to exercise, move. One of my patients told me her doctor said, you're fat every day, so you should exercise every day. So this like, eat less, exercise more. And so then people are like out there busting their asses and physiologically like damaging their bodies, damaging their psyche, because they feel like they must just do that because they live in this body, and it's almost like being beaten. It's like it's a really oppressive experience to just keep physically pushing yourself past the point when you should be. And doctors are prescribing this, and like more movement the better. No attention to self-care, mindfulness, what's feeling right, what's not feeling right. And so there is this, I'll call it exercise trauma, that the medical field and the eating disorder field also, I think, and it happens to kids, like the presidential fitness challenge, kids going in a public setting where they're supposed to like climb the rope. I couldn't climb the rope. I could never climb the rope, but imagine somebody who's living in a larger body and whether or not they could climb the rope, and you're timed for your run and all this bull crap, and you're 9 years old and you're very sensitive. So there's this like perpetuation of exercise trauma that particularly affects those who are living in a larger body, who may not, they may need a different type of movement. But it happens in treatment centers a lot, not having the furniture that people need to feel comfortable within a treatment setting. I've been guilty of it myself. I've been working really hard to get better and better at it, but I've been guilty of that myself, not realizing, hey, I need to like look at my community and how's everybody going to feel in this setting. So that's another thing that weight stigma awareness is about making not just treatment centers, but making the world accessible. Because when we were doing that impact council, one person said, and I realized it was so true, people who experience weight stigma that are like going for restrictive diets and stuff like that, or trying to lose weight, they're just trying to have access to things that are just normal. They want access to love too. They want access to acceptance. They don't want to be punished for, like, interpersonally punished just for being who they actually are. And so this is the core of restriction in all forms of eating disorders, but it is especially prevalent for somebody who's experiencing the day in and day out trauma associated with it.
Absolutely. So I feel like we could talk about this for many more hours. There's so many more questions I'm sure we all have, and yet we are here with just about a minute and a half left. So I want to make sure to invite everyone to programming for the rest of the day. I know Dr. Wendy is speaking again at 2 p.m. Eastern. Is that
yes.
correct?
Mm-hmm.
For a complete list of programming today, please go to your CE-GO dashboard. And then we can pop back into our chat for a moment, just for some closing thoughts. How can individuals and organizations collaborate in supporting Weight Stigma Awareness Week? There's so many topics that we just got to touch the tip of today, and so much more work to do in this.
Yeah, I think. Oh, sorry, Katie.
Good.
The most important, go to weightstigmaawarenessweek.com. Look at the resources there. Like I said, all of the talks will be up. We've already done them. We're getting them ready to put on YouTube, and then they'll be linked from the website. If you work in a situation where you're in a outpatient center, or you're in a residential center, academic center, whatever. I just did a video yesterday that I posted on my Instagram, because I do some support groups, and I also work with big brands and help them understand how to do their marketing to be more inclusive of larger bodies. But I'm like at the end of my rope with the treatment community in the eating disorders field. The education is out there. People have to get it. And whether these treatment centers hire me or somebody else, or just do the work on their own, we've got reading on our website, but I can't tell you how many people on a daily basis I hear stories from about how they were stigmatized in treatment centers.
Mm-hmm.
And I would think that most clinicians don't even know they're doing it.
Mm-hmm.
And there is an intersection between other marginalizations, whether you're in the LGBTQIA community or BIPOC community or whatever. That's why we're all talking about this stuff so much. There is so much harm being done. And the treatment provider community is just kind of going along like,
Mhm.
this is what we do. And I mean, I hate to sound like an angry person, but I am. I'm really angry
You're
because
allowed to be angry, Sharice, and thank
people
you for
are
being angry.
really, really being harmed. And that's why I trust to send people to Wendy, because I know that won't happen. But there's really no other place in the country that I will send people who are higher weight, because I don't trust. I do not trust. And
And
so
we're
whether
sure
you
we're
do it
so-
individually or you say to your advisors, like, we have to do this work, it's part of your responsibility to people. So I'm not saying that to everyone here individually. I don't know your stories, obviously, but it's going to take all of us really encouraging this community to make change.
And may I just say something too? Sorry, I know we're over, but that is why we started Weight Stigma Awareness Week. And I think, Chevese did an amazing job getting people like speaking at Weight Stigma Awareness Week that have not had a voice in our field, which was amazing to watch. Like, a lot of people like me just need to get the hell out of the way so people who have been through this can, like, do what they need to do and explain, tell their stories. And I just wanted to add, like, that in addition to the treatment communities, the other place is, and that's why I'm giving this talk in the healthcare office. So when we were doing our impact council, I mean, literally every person in a larger body just, has horrible stories of what has happened in the doctor's office. And basically, folks in larger bodies end up avoiding getting health care because of it. And you go in to get, we were hearing about, you go in for medical problem X and you go out, with a diet. And one of my family members was saying to me, like, she literally knows it's going to happen. So she tries to go in and preempt the preaching. I already know, like, because she doesn't want to experience that pain and that shame. So she tries to, like, get ahead of it. I know, like, please, and it's just so hard to get her to go to the doctor because of that. So, and helping people understand that they don't necessarily have to get weighed at the doctor, like, is another thing. But anyway, Chevese, wrap it up with final words, if you don't mind, because I know you can say the final bottom line.
Yeah, I think the bottom line is just continue to get education, and there's many of us out there who are doing this education for clinicians and treatment centers and larger entities, healthcare communities, and so forth. And I know it's a different paradigm, that the thought of not putting somebody who is fat on a diet just seems so counter and to the messages we get every day, but it really does not help, and it just produces more and more shame and stigma. So that's really my bottom line. And thank you all so much for being willing to be here and listen and learn. And I'm my email. Can you put my email in the
Tell me
chat,
what this
Katie?
is.
It's Chevese@bodyequityalliance.com. And I'm always happy to chat with anybody who may have any questions.
Chevese@bodyequityalliance.com.
Yep.
Thank you
Thank
so
you all for being here.
Thank you so much to our speakers and to all of our wonderful guests. Can't wait to see you later today at the other programming. I hope everyone has a beautiful day.
Thanks, Katie.
Thank you.
Bye.